Hi everyone, this is Mr. Neil Writer, consultant audiologist and director of ClearWax. Thank you for joining me in another demonstration video of our recently developed WAXscope, which is due to be launched very shortly indeed. If you are interested and want to be added to our mailing list so you're kept up to speed with all the developments and the release date, please do email info@clearwax.co.uk. So we have a patient here who attended with an extremely narrow ear canal. As you can see, the ear canal is what we call slit. Now all of our ear canals are oval shaped. The height is greater than the width, so it gives it kind of an egg dimension or American football dimension. But this patient's ear canal is more elongated than that, so the height is significantly more greater than the width, and it's just over the years this patient has got a collapsed ear canal. They've suffered from many ear infections. It's what we call a bit of stenosis when the ear canal just narrows due to chronic infection. So when you're suffering from chronic ear infections, you get loads of inflammation of the skin, the bone, the cartilage, and over time it just narrows as a result. And subsequently, this patient is now suffering from chronic buildup of dead skin. So all this is dead keratin skin. And if you saw the thumbnail, you'll see there's a tremendous amount that I removed, especially considering how narrow this ear canal was. And I commenced with a bit of microsuction. And quite often when you've got skin like this, it's difficult to get a suction grip. And this skin is also attached, it's adhered to the canal wall. So I'm also using in combination a St. Bart's ear hook. I'm using the ear hook, trying to separate the dead skin from the canal wall, but also to prise it out and also to chisel it into little pieces. So one of the things I've learned over time with experience, when I used to use a St. Bart's ear hook, it was always an objective of mine to remove a large piece of wax out of the ear. But I've come to realise that although you still can in certain cases, you can use the St. Bart's ear hook in combination with suction like we're doing here. We can break up the wax into little smaller pieces and then use the suction, microsuction to remove from the ear. Currently, I'm using our medium-sized specular, a 4.25mm specular. But as I go deeper in the ear, I'm going to revert to the smaller one because you can see ahead, you can see the canal wall either side. And this specular, although I'm using it to stretch and trying to straighten the ear, you can probably see me stretch and straighten the ear just here as well. I've managed to get it through that narrowing, but as I go deeper in the ear canal gets narrower and narrower, so I'm going to use a smaller speculum size in a moment, or a bit later, I think it's a couple of minutes away still. So I've now also introduced a Jobson horn. So with the Jobson horn, it's got greater surface area, so quite often, if we can get in behind the wax or the skin, we can leverage it out, lever it out. So you can see I'm using a combination of all the instruments. I've not used forceps because forceps would be difficult in this particular case because of how narrow the ear canal is. It'd be difficult to, so once you're in with the forceps, you have to open the jaws. And it'll be difficult to open the jaws because the cartilage of either side, because it's narrow, it's not wide enough, the ear canal really, to house the forceps. But nonetheless, slowly but surely, we're tunneling through this dead skin and wax, and you can see it's really crusty. The darker bits of skin are the parts, the bits of the skin that's been longer in the ear canal, so it's oxidized. And again, I'm just stretching the ear open, I'm just adjusting the focus. As we go deeper into the ear, we just need to increase the focus. So we're probably about halfway or just past halfway into the ear canal now, so we're about 1.5 centimeters, maybe going up to 2 centimeters. And this more medial wax and dry skin is formed into a plug. It's lodged, and going to go in with the ear hook, and we're going quite deep now. So one of the things I've noticed with the WAXscope is that I feel more comfortable using a hook deeper in the ear, and that's in part because when you're using the WAXscope, the speculum is straight in the ear canal. And when you've got the ear canal completely straight and you put the ear hook in, you're less likely to make contact with the side walls of the canal and make it uncomfortable for the patient. When you're using an endoscope, you're stretching the ear canal open using the endoscope, but the angle of the ear hook just comes in slightly more perpendicular, so you're never always quite straight, whereas with the WAXscope you are entering, the angle of entry of the ear hook is more straighter. Now, we are working with a company, and there's going to hopefully be soon, I shouldn't say too much really, but a new device, an instrument that we're going to develop. I wouldn't say we are developing it. Well, my colleague is. I've got to give my colleague full credit for it. We're just modifying certain aspects of it, just so it's easier to use for the specialists. So more to come with that in the future. At the moment, we're just really focusing on launching the WAXscope, and we're nearly there. We were sent some images and videos of our tooling machine, which manufactures the speculum that you're seeing. And I've been rest assured that I was meant to get my sample speculum this week, but I've been rest assured that I'm going to receive it next week. Now, we're going further into the ear. I don't know whether you've noticed, I've switched over to the smaller speculums. This is a 3.5, and it just allows me to enter the ear a bit further. You can see I can stretch the ear a bit deep. With the 4.25, it was okay more laterally near the entrance, but as we go deeper, the ear canal's narrowing, so I just need a smaller, narrower speculum to suit. So I've put some olive oil spray in here just to loosen some of these skin adhesions. You can see I've just peeled it away from the bottom of the ear canal, and I'm just going to wriggle this out. But it's quite a chore wriggling it out, because all this debris that I'm removing, it's larger than the midsection of the ear canal, because the midsection of the ear canal in particular is really narrow. Beyond that, the ear canal widens a little bit. So we're bringing through loads of wax, dead skin through a narrow midsection. So of course it's going to get trapped, so we have to wriggle it through. Again, I'm just really inserting the specular as far as it goes into the ear. So with the specular we're using, you can't over insert it because we've got a flared, what we call proximal end. So so think about a specular like a hollow funnel. The tip of the funnel is much narrower than the entrance of the funnel, and the entrance of the funnel is outside the ear, and the tip of the funnel, the speculum, is inside the ear, and the section of the speculum outside of the ear, it flares out, so it's impossible to over insert because it will get trapped, and that's a safety aspect. We've done that on purpose, so we don't want specialists to over insert the speculum into the bony part of the ear canal where it can be uncomfortable. So the speculum should just terminate the tip at the end of the cartilage portion, so what we call the osseo-cartilaginous portion of the ear canal. It's roughly 1.2, maybe to 1.5 in some cases, centimeters into the ear. So this is this last piece. It's really, really deep. You can see all this skin, especially on the right-hand side. That skin, it's very thick, and it's attached to the canal wall, and as you can see, I'll just leave it out. You may have noticed there wasn't much wriggle room with the speculum. There's hardly any space for me to maneuver the speculum. And you can probably tell by I don't know, you'll see it a bit later, but this patient has got otitis externa. There's eczema and psoriasis, an eczema oral psoriasis of the ear canal. And it's made the ear canal, the wall slightly inflamed, slightly red. They do have medication already prescribed by the GP. I don't know if you can see that to the right. Just put some more oil in there as well, just to loosen this last bit. So I'm just getting the focus. You can see how we're adjusting the focus. And this piece of wax and dry skin is actually suspended from the roof of the ear canal. You can see the bottom part of the ear canal is clear, but it's attached at the roof. So I'm trying to bring it down and towards me. So down towards me. I don't want to let go of the suction grip. I've got a good suction grip here. Here we are. It's going to wriggle it out of the ear. And that was a really dry, crusted piece, that particular piece was. And we're just going to re-enter the ear in a moment. There we are. We can see the patient's eardrum. I've got it in focus. Look, it's extremely clear. We can see all the individual blood vessels on the hammer bone, the handle of malleus. I hope you enjoyed that video, guys. And again, if you are interested in the WAXscope, please do email info@clearwax.co.uk.